So, like we were just saying, new interventions come in with their own complications, and the reason we started to address the angle was to get away from the complications related to blebs. But of course, it's just they come in with their own sets of newer complications. So the angle-based procedure is basically you incise the inner wall of Schlemm's canal and connect it to the anterior chamber, either through an ab externo trabeculotomy or an ab interno KDB or GAT. I usually go for the circumferential incisions, whether ab external or ab internal, because I believe it maximizes the outflow of aqueous. And at the same time, if it scars later on, you're more likely to find patent parts of the angle that are still functional. We now have the 4-year outcomes of GAT, and it shows that the chance of having a pressure of 15 or less is 63%, with 44% of the patients off medication. So it's really worth exploring those complications and trying to minimize them as much as possible. So these are the ones specific to GAT and angle surgeries, generally, false passages, hyphema, and spikes. And false passages happen with the ab external as well as the ab internal approach, but of course they're less common with the ab internal because it's under direct visualization of the angle. And the first rule of thumb is to prepare your tools well. If you're using a suture, you don't want a knob like the first one. You want just to smooth out the tip of the suture, just to get it to move smoothly and be threaded without getting obstructed. You don't want a mushroom and you don't want a big knob. You just want it to be smooth so as not to injure the Schlemm's canal. One needs to be very familiar with the angle appearance in this particular patient, both preoperatively on the slit lamp and intraoperatively. If you need to familiarize yourself with the angle structures. It doesn't hurt to gently dissect the tissues, clear up the scleral spur, make sure that you're in the correct plane before going in with the MBR and incising what we think is trabecular meshwork. And it becomes a bit tricky in children because their trabeculum is hypopigmented. So in those eyes, it helps to deflate the angle. I'll show that in the coming video. And at the same time, once you're in, whether in adults or peds, we need to make sure that the first passage of the suture or catheter is covered by the inner wall of the Schlemm's canal. It appears that the grayish tissue covering the suture we have. Once it goes through the first quadrant, it's very unlikely to separate from the Schlemm's canal. Usually it completes the incision in the blind spots you have around the limbus. Well, if you follow it in the first quadrant and get it through that part, it's very unlikely to misdirect. But sometimes, infrequently, it does, particularly in children. They have a sort of fragile Schlemm's canal. So sometimes, even though your first entry is very correct in the correct plane, you'll be surprised that the suture leaves the canal prematurely and comes out of the opposite side. This is manageable. You can still create your incision and then go in from the opposite side, just like with the Omni device, do it through a two-side 180 degree. This is how to locate the Schlemm's canal in cases where it's equivocal or hypopigmented. You can deflate the anterior chamber. The blood will regurge into the Schlemm's canal, delineated, and then you can reinflate it so you don't want this blood into the anterior chamber. In cases that have had previous surgeries, it's prudent to start away from the problematic area of the previous trab or tube. So in this case, with the trabeculectomy placed on the right side, I would start in a anti-clockwise direction, just in case the suture stops at the site of the previous trabeculectomy, and then you can complete your incision from the opposite side, this quadrant that was left out. Now, suprachoroidal passages are one of the nastiest complications. They can pass unnoticed. Sorry. Sorry. Yeah. The worst thing is if they pass unnoticed. So they happen more frequently as we're starting to learn the gap procedure. And become much less frequent later on, but still in some cases they're just unavoidable. So this patient that had a previous trabeculectomy, as you can see, the suture has passed 180 degrees and then the direction is completely changed at the site of the trabeculectomy into the suprachoroidal space. And the rule of thumb is to try to detect it timely. So you need to eyeball how far you've gone with your suture. So if it's going on and on and on, you need to stop and address the misdirection. It can become misdirected from the start. And as I said, this improves with the learning curve as we're learning GAT, but it's very important to make sure again. So here it keeps finding its way into the suprachoroidal space from the start. But if it goes into the correct plane, you can make sure of that by pulling on the suture, and you'll find that it's completely parallel to the iris rather than sort of perpendicular or going in at an angle. And you can see the floor of the Schlemm's canal. And in this case, you can confirm that it's gone into the correct plane, and in this case it will hopefully come out of the opposite side. Now, with the ab external technique, you're more likely to misdirect because a lot of the procedure is blind. So you can find yourself in all sorts of funny planes. So as you can see here, although the probe is going in very smoothly into some plane there in the tissues, as I'm trying to incise the Schlemm's canal, there's intense resistance, and it turns out that it's intrastromal and risks creating a Descemet's membrane detachment. But when the section is relocated into the correct plane posteriorly, again, it goes in smoothly, but then in this case, it can dissect into the anterior chamber successfully as well. I find it very helpful when I'm doing the ab external, and by the way, I do it in adults as well with opaque corneas where GAT is not possible, is to deroof the Schlemm's canal, because in this case you can detect a tear, just like the brown line that was in the grayish floor of the Schlemm's canal. You can still avoid it, just like when you detect a posterior capsule tear and still be able to implant your IOL. But if it goes undetected, you risk having a fallen IOL. So it's important to examine the floor well, make sure that it's the actual Schlemm's canal. One of the sure signs with the ab external is to actually find the inner wall at the tip of your trabeculotome. In this case, then you've definitely nailed it. Now, hyphemia is a real nuisance. It happens post-operatively, but it's manageable, and in most cases, it goes away with conservative treatment, no matter how long it takes, up to a month. Very rarely do I need to wash the anterior chamber. But intraoperatively, it can get in the way of visualization. There are a lot of surprises. I've operated on a lot of patients who had to continue on their anticoagulants and didn't find any bleeding. And then you get a healthy young adult with juvenile open-angle glaucoma, and they bleed horrendously on table, even though the iris is untouched. So we need to use high viscosity visco cohesive, wash the anterior chamber every time. Whenever we feel that things are too cloudy and we can't visualize, we need to stop and wash. And if it goes between the lens and the cornea and hinders visualization, then it's okay to just stop, wash everything, and start a new clean start. And I find it very helpful to raise the head of the bed 45 degrees. Now, finally, spikes. And spikes are really scary. And when you look at the literature, although they happen almost equally in TRABs, but they were not as scary with TRABs. And the reason is we don't know with the GAT and angle surgeries why they happen. That's the thing. The cause is unknown. With the trabeculectomy, you know, if you massage, you've tightened the sutures, 20 seconds. You've tightened your sutures, but with the GAT, we don't know why they happen. There is some evidence that they're related definitely to steroid use, but even though I've been putting patients, I have not been using steroids post-operatively at all for 2 years, they still happen. They're more common in juvenile cases, around 75%, but generally, for other patients, it's around 24%. It takes around 5 days on average, but it takes a lot more of your own life expectancy because they're really scary. You have a patient with a pressure of 8 post-operatively, and then a couple of days later, they call in with headache, pain, and a pressure of 45. And it goes down in most cases, but we still don't know why they happen. And again, that's one of the obscure things with angle surgery that we're still learning and exploring. A lot of things, but we need to continue to learn how to approach them for the best sake of these patients. Thank you.